Myself, Dr. Chetan Javsen. Today we are going to discuss about the peptic ulcer, pathophysiology and pharmacological management. Okay. First definition of peptic ulcer. Peptic ulcer are the open sores that develop on inner lining of the stomach and the upper portion of the small intestine. If there is a open sore in the gastric stomach called as gastric ulcer, in duodenal called as duodenal ulcer. Okay. This is a gastric ulcer and this is a duodenal ulcer. The etiology of peptic ulcer, cause of the peptic ulcer are the Helicobacter pylori infection, NSAIDs, stress, smoking, alcohol consumption, and genetic predisposition. These are the etiology of the peptic ulcer. Okay. Then pathophysiology of the peptic ulcer. There is an imbalance between the aggressive factor and the protective factor. Aggressive factor are the acid, pepsin, and H. pylori are the aggressive factor causes the peptic ulcer. And protective factor are the mucus, bicarbonate, prostaglandin are the protective factors. Okay, when there is a imbalance or overpower of the aggressive factor causes the peptic ulcer. Okay, is the imbalance between the aggressive factor and the defensive factor. There is causes of the cause of the peptic ulcer. Okay, then sign and symptom of the peptic ulcer: epigastric pain. Pain tend to be worse at a night and occurs 1 hour to 3 hours after meal. Nausea, vomiting, belching, significant weight loss, feeling of fullness, pain or discomfort in upper abdomen, and bloody and dark stool. These are the sign and symptom of the peptic ulcer. Okay. Then complications, there are two main complications: bleeding and the perforation. These are the main two complications of the peptic ulcer. Okay. Then the regulation of the acid secretion. Gastric acid production is regulated by the acetylcholine and hormone gastrin and the histamine. They stimulate directly to the parietal cell. This is the final step in the acid secretions. They stimulate the parietal cell to produce the gastric acid. Acetylcholine and gastrin act directly on the parietal cell and indirectly on the enterochromatin cell to secrete the histamine. It means that acts on the enterochromatin cell, stimulate to secrete the histamine. Okay. Then gastric acid secretions, hydrogen, first is the hydrogen ion generation. Hydrogen ions are generated from the CO2 and H2 to form H plus and HCO3 ions. Bicarbonate are transported out in the exchange for the chloride, and hydrogen and pumped out of the cell into lumen in exchange for the potassium through the hydrogen potassium ATPase pump or the proton pump. This is the diagram of the HCl secretions, formation of HCl. Okay. Then classification of the anti-ulcer drugs. First, the antacid, H2 receptor blocker, proton pump inhibitor, mucosal protective agents, and the H. pylori therapy, anti-H. pylori therapy. These are the 5 class for the for the peptic ulcer. Antacid, H2 receptor blockers, proton pump inhibitors, mucosal protective agents, and anti-H. pylori therapy. This is the classification of the drug used in peptic ulcer. First is the gastric acid secretion inhibitor. First class H2 antihistaminics, example cimetidine, ranitidine, famotidine, roxatidine. Second is the anticholinergic drugs, pyrazine, propanthelin, oxyphenonium. Third is the proton pump inhibitors, omeprazole, esomeprazole, pantoprazole, lansoprazole, rabeprazole, dexamethasone. These are the proton pump inhibitor. Next is the prostaglandin analog, example misoprostol. Next class is the gastric acid neutralizing drugs, also called as antacid. Antacid are two types: systemic and non-systemic. Systemic antacids, example sodium bicarbonate, sodium citrate. Non-systemic antacids are the magnesium hydroxide, magnesium trisilicate, aluminum hydroxide, megaldehyde, and calcium carbonate. These are the non-systemic antacids. Next is the ulcer protective agent. Example sucralfate, colloidal bismuth substrate. These are the ulcer protective agents. Next class, drug used against the H. pylori infection: amoxicillin, clarithromycin, metronidazole, tinidazole, tetracycline, and CBS. These are the drug action against the H. pylori infection. CBS has both the activity ulcer protective drug also against the H. pylori infections. First class is the antihistaminic class. This competitively blocks the H2 receptor on the parietal cell and inhibit the gastric acid secretion. These drugs act on the H2 receptor in the parietal cell and suppress secretion of the acid in all phases, but mainly nocturnal acid secretion. Also reduce acid secretion stimulated by the acetylcholine, gastrin, and the food. This is the action of the acetylcholine that acts on the H2 receptor on the parietal cell. Okay. Then pharmacokinetics: absorption is not interfered by the food, can cause placental barriers and reach milk poor sinus penetration, means it is contraindicated in the pregnancy and lactating woman. Serum half-life ranges from 1.1 to 4 hours, clear by combination of the hepatic, metabolic, glomerular filtration, renal tubular secretion. Means dose adjustment needed in moderate to severe renal insufficiency. Comparison of the H2 antagonist. Viability, cimetidine 80%, ranitidine 50%, famotidine 40%, nizatidine more than 90%. Relative potency, if you are comparing the, considering the cimetidine has a potency 1, then cimetidine 1, the potency 1, ranitidine 5 to 10 times than cimetidine, famotidine 32 times, nizatidine 5 to 10 times than the cimetidine. Half-life, cimetidine 1.5 to 2.3 hours, ranitidine 1.6 to 2.4 hours, famotidine 12 hours, nizatidine 8 hours. Inhibition of the CYP450 enzymes is the metabolic enzymes in liver. Cimetidine mainly inhibit the metabolic enzymes CYP450. We are comparing this with cimetidine. Ranitidine comparison nearly 0.1 times than the cimetidine. There is no inhibition of by the famotidine and nizatidine. Those is cimetidine 490 milligram, ranitidine 150 milligram, famotidine 20 milligram, nizatidine 150 milligram. And duration of action is cimetidine 6 hours, ranitidine 8 hours, famotidine 12 hours, and nizatidine 8 hours. Okay. Uses mainly use of the H2 antihistaminics are the promote the healing of the gastric and duodenal ulcer, NSAIDs induce ulcer, stays ulcers and gastritis, Zorinja-Ellison syndrome prophylaxis for the aspiration pneumonia. They are use of the H2 antagonist. Adverse effect are the headache, dizziness, bowel upset, dry mouth, CN, confusion, restlessness, bradycardia, arrhythmia, cardiac arrest. Cimetidine has a anti-androgenic effects. This is the main adverse effect of the cimetidine. Okay. Drug interaction, cimetidine inhibits the CYP450 isoenzymes and reduces the hepatic blood flow. So inhibit the metabolism of the many drugs like theophylline, metronidazole, phenytoin, means this cimetidine increases the plasma half-life of the theophylline, this drug, metronidazole, phenytoin, and imipramine. Antacid also reduce the absorption of the H2 antagonist, means antacids are contraindicated with the H2 antagonist. Then next slide is the proton pump inhibitors. Proton pump inhibitors are most potent inhibitor of gastric acid secretion. These drugs mainly inhibit the final pathway, the acid secretion. Used in treatment of the peptic ulcer, gastrointestinal reflux diseases, Zorinja-Ellison syndrome. These are the common use of the PPI. Example are the omeprazole, esomeprazole, pantoprazole, lansoprazole, zol are the proton pump inhibitors. Mechanism action, they irreversibly inhibit the hydrogen potassium ATPase enzyme or proton pump in gastric parietal cell and suppress the final step in acid secretion. Okay, this is the final step of the acid state. This proton pump inhibitor inhibits the hydrogen potassium ATPase pump. That pump transfer the hydrogen ion in the lumen. It's the final step in the acid secretion. Okay. Pharmacokinetics, acid, this is acid labile. Always these preparation always in form of the enteric coated tablet. Enteric coated tablets mainly prevent the degradation of tablet in the acidic environment when it go to small intestine, then only dissolve and absorb in the small intestine. Absorption in the intestine activated in the acidic canaliculi of the parietum. When it's absorbed from the small intestine, again enter in the systemic circulation, then it secrete in the canaliculi of the parietal cell and acts on the parietal cell. It has a short plasma half-life and long duration of action. Therapeutic use mainly for the peptic ulcer disease, GARD, Zorinja-Ellison syndrome, Stay's ulcer, H. pylori, and for the H. pylori eradication as part of the triple therapy or the quadrupedal therapy. Okay. Adverse effects are headache, nausea, abdominal pain. Long-term area are the B12 deficiency, hypomagnesemia, and fracture. Increase the risk of the infection. These are the adverse effects of the PPI. Drug interaction may reduce absorption of the drug needed for the acidic phase. Means some drugs require the acidic phase for the absorb, mainly for the weakly acidic drug. Example, ketoconazole. So these PPI mainly inhibit the absorption of the acid labile drugs, or that drug that require the acidic environment for the absorption. Omeprazole inhibit the CYP2C9 enzymes can affect the copidoglycan activation. Then next class is the antacids. Antacids are the basic substance that utilize the gastric acid. provide symptomatic relief in the acid-related disorder. This inhibits only the acid, neutralizer acid. The classification of the antacids class systemic antacid and the non-systemic antacid. Systemic antacid, example sodium bicarbonate, sodium citrate, these are the systemic antacid. Non-systemic antacid are the magnesium hydroxide, aluminum hydroxide, calcium carbonate. These are the non-systemic antacid. Systemic antacid means they absorb into systemic circulation and they secrete in the stomach. And non-systemic antacid act locally. Example, magnesium hydroxide, aluminum hydroxide, calcium carbonate. These are the non-systemic antacid. Then mechanism of action, antacid react with HCl to form the salt and water, increase gastric pH and decrease the pepsin activity. First is the magnesium hydroxide. It's a fast acting, the potent. Main area is the diarrhea that often combined with the aluminum hydroxide because aluminum hydroxide causes constipation. They balance the adverse effects of the both the drug, magnesium hydroxide and the aluminum hydroxide. That's why magnesium hydroxide is combined with the aluminum hydroxide as a antacid. Aluminum hydroxide is lower at one side. Idea is the constipation. Bind phosphate and can cause the hypophosphatemia because aluminum hydroxide bind to the phosphate. Next is the calcium carbonate. The potent neutralizer, ADR, the hypercalcemia, milk syndrome, may cause the rebound acid secretion. Next is the systemic antacid are the sodium bicarbonate, rapid onset short duration of action. ADR are the main area is the systemic alcohol. What is the systemic alcohol? Because it is absorbed into the systemic circulation. And CO2 production can cause the flatulence. Not recommended for the long-term use because of different causes the alkalosis. Adverse effects of the antacids alter the bowel habits and causes constipation, diarrhea, and causes electrolyte imbalance. Drug interaction can cause chelation with the tetracycline and fluoroquinolones. Therapeutic use for the peptic ulcer, GARD, dyspepsia, and use as actual therapy with the PPI. Can be used with the PPI. Drug interaction can cause chelation with the antibody tetracycline quinolones, alter gastric pH, affect the absorption of the water bottle. The interaction of the antacid. There is a muscarinic antagonist. It's not commonly used. It blocks the M1 class of the receptor, reduce acid production, and abolish the gastrointestinal spasm. Example of pyranzapine, telanzapine are the muscarinic antagonist. They act on the M1 receptor. Reduce milk-stimulated acid secretion by reversible blockage of the muscarinic M1 receptor on the cell body of the intramural cholinergic ganglion. It reduces the milk-stimulated HCl secretion by reversible blockage of the muscarinic M1 receptor on the cell body of the intramural cholinergic ganglion. It's unpopular first choice because high incidence of the anticholinergic side effect. What is the anticholinergic side effect? Dry mouth, blurry vision are the anticholinergic side effect because of this M1 antagonist, not commonly used as an antacid. Okay, these are the acts on the M1 receptor on the ganglionic cell. Then next is the ulcer protective drugs. Drugs that protects the ulcer. Ulcer protective drug enhance the mucosal defense mechanism. Acts on the enhancing the mucosal defense mechanism. That does not alter the acid secretion significantly. They alter the acid secretion. They just protect the ulcers. Example: sucralfate, bismuth compounds, misoprostol, carbendazole. These are the ulcer protective agents. Okay. Sucralfate is a sucralfate, sucrose, aluminum hydroxide from the viscous chain that bind to the ulcer base. Promote healing and protect from the acid and the pepsin. Means this drug may protect the ulcer from the acid. Given on an empty stomach, ADR are the constipation, interfere in the absorption of the other drugs. Means this drug can be interfere in the absorption of the other drugs. Bismuth compound, example colloidal bismuth substrate, CBS. It also has a anti-H. pylori activity also. Coat ulcer base and stimulate the prostaglandin mucus secretion. This bismuth CBS acts as the also protective agents, also inhibit the H. pylori infection, also stimulate with the prostaglandin and mucus secretion. ADRs are the black tongue and the black stool. These are the adverse effect of the bismuth substrate. This is from this types of the coat mucus protective layer developed with the help of the ulcer protective drugs and prevent the action of the acid on the ulcer. Misoprostol is a prostaglandin E1 analog. Increase mucus, it stimulates secretion of the mucus and bicarbonate. Also inhibit acid secretion and indicated for the NSAIDs induced. This drug mainly used for the NSAID induced ulcers, diarrhea, abdominal cramp, uterine contraction. This is contraindicated in the pregnancy. Misoprostol is the main non-contraindicated indicated in the pregnancy. Carbexolone, these are derived from the glyceric acid, leucolytic roots, enhance the mucus production and prolong the cell lives. Rarely used due to the mineralocorticoids side effects. These drugs have a corticosteroid mineralocorticoids side effects. Corticosteroid nuclei. The mechanism of the mucosal protective agents strengthen the mucosal barrier, stimulate mucus and bicarbonate secretions, enhance mucosal blood flow and cell regeneration. Okay. Clinical application mainly for peptic ulcer disease, stress ulcer disease, prophylaxis, NSAIDs induced ulcers as an adjuvant to acid suppressive therapy. Okay. They are the clinical application of the drug used for the ulcer protective drugs. Okay. Now next is the H. pylori. Drug against the H. What is the H. pylori? Is the gram-negative rod associated with the gastritis, gastric and duodenal ulcer, gastric adenocarcinoma. Okay. Transmission through the oral fecal route. Secrete urea, convert urea to the ammonia and produce alkaline environment. Enable survival in the stomach. Means these H. pylori produce the alkaline environment for their survival in the stomach by conversion of the urea to the ammonia. Higher prevalence in the low socio-economic class. Okay. Therapy, mainly two therapy, triple therapy and quadruple therapy. Triple therapy contain BPI, proton inhibitor with erythromycin plus azithromycin or the metronidazole. Quadruple therapy, proton inhibitor, bismuth substrate or colloidal bismuth, tetracycline and the metronidazole. These are the H. pylori therapy. Then case-based learning, if the 45 years old male with epigastric pain, smoker, NSAIDs use, most probably diagnosis and treatment. 45-year male with epigastric pain, especially smoker and NSAIDs use, no diagnosis and treatment or approach. Then rational use of the drug. Step-point approach, start with H2 blocker, escalate to the PPI if needed. Combine with the lifestyle changes and avoid the long-term insights. Adverse drug reactions. Those proton inhibitors, main adverse drug reaction are the B12 deficiency, chronic use of the PPI causes the B12 deficiency, fracture, infection. H2 blocker causes the CNS effect in elderly. Antacid alters the absorption of the water drug. These are adverse effects of this drug used in the peptic ulcer. Okay. Monitoring and patient education, monitor symptom of relief and ADR, counsel on drug adherence, avoid smoking, avoid alcohol, NSAIDs, use of the NSAIDs, importance of the completing H. pylori therapy. Means summary peptic ulcer result from the imbalance between the aggressive and defensive factor, multiple drug class use and rational prescribing essential. MCQ.